Good morning, good noon, good afternoon. Happy Thursday, everybody, or maybe even Friday for some of you, depending on where you're joining. Welcome to VMR. It's a very nice day here in San Francisco, and I hope it's the same for you. Most of you are probably familiar with the Thursday theme. The Thursday theme is that I get to discuss with our CP Solvers Academy team members. For those of you who are becoming more and more familiar with this, the CP Solvers Academy is a group of people in medicine in all stages, from MS2s or MS3s to seasoned professors of medicine like Prof. Res. And then the rest of us are kind of sandwiched in between. And we all have a borderline / maybe overt pathologic love for medicine, but it actually, what we realize is as we've come together as a group, we realize that we connect over much more than just the medicine. And this group has existed informally for maybe 3 or 4 years, but more formally for the last few months. And as part of these Thursday exercises, we celebrate the successes of team members who have come in and shined. And today is exactly that. And today I will be accompanied in the discussion seat by none other than Francisco, who I think will be a very familiar name to you all. Yes, as we just discussed, sounds like he might be Italian or from other parts of the European or Latin continent, but no, he's from Portugal, our second ever team member from Portugal. And we all crossed paths with Francisco, actually sort of subacutely, peppered throughout the history of VMR, but then more acutely over the summer, where it was very clear that he just absolutely loved medicine and came and presented a bunch of cases in VMR. And I remember talking with the leadership team and being like, oh, we all were like, we have to bring Francisco, but we've just brought in so many team members. We should wait. And ultimately realized we just couldn't wait any longer because he was making such a positive impact. That was the pre-phase of Francisco's involvement. In the intra, to maybe set us up for a schema here, the intra phase has been equally emphatic. And I think what I just talked about with regards to us bonding over medicine and much more, Francisco has bonded with us over medicine in many ways, including actually being the idea generator and presenter of one of our most popular VMRs, which is my losing battle with ChatGPT, though we both lost. But you know what's really cool, as I was chatting with another Academy member, Noah, so Francisco and others are part of the really cool initiative that brought to life what it means to be a CPS Solvers Academy member outside of medicine. These guys, a lot of them are matching this year. And not only have they been supporting each other in the math process with words of support, Francisco and a couple of others of his teammates put that support into real life action and actually created a program where they mentor each other and coach each other on the interview process. And so not only is it just verbal support, it is literally practical, and nothing can symbolize better how much these people have each other's backs than supporting each other through a very competitive and very rigorous match. Francisco, we started the pre, we've done the intra. I'm really hopeful that there's no post, but if you have a really bad time today, I will totally understand, because we have Shema who's presenting a case, and when Shema is presenting a case, I think we're all in for a treat. But I'll pass the mic to you, Francisco, to say hello, and then to Shema, and then we can jump right in.
Hi everyone, friends. So it's a pleasure to be here. Along these past 3 or 4 months, I've made some amazing friends. It all starts like Rabih says, with a passion for medicine, but then it just goes way beyond that, and we connected in those initiatives to support each other, to advocate for IMGs. We shared passion for soccer, for many other things, and I still have a soccer match to play with Rabih. We still need to arrange that. I'll call my friend Cristiano Ronaldo and see if he can hop on a private jet and go to San Francisco. That would be good. And it's such a pleasure. Let's just have a great time. And also, it's great to have a Shema case here after quite a while. And let's have fun, guys.
Okay, then, so before I start, and thanks for the very nice introduction, and I want to give a shout out to Ravi with a V2 because he gave me this case because he thought I might very like it because I have a phobia for one specific topic, and you will discover it through the discussion, but I think Francisco will rock it. So then, could you please share the whiteboard and I can start with the first aliquot? So, just a moment. Okay, so first of all, the chief complaint of this case is blurry vision and eye pain. And in this case, we have a 28-year-old female who has a history of hypertension, currently not on any medication. She also has anxiety, who presented to the ED with 2 weeks of eye problems. She was in her usual state of health 2 weeks ago when she started using contact lenses. Several days later, her right eye started to feel irritated and her vision became blurred. She went to her optometrist who prescribed topical steroids and antibiotics for possible irritation due to contact lenses. However, her symptoms continued to worsen and she developed worsening right eye pain with decreased vision, redness, and difficulty with eye movements. She was sent to the ED for emergent evaluation by her optometrist. And I would start right here.
Francisco, yes, you're a budding ophthalmologist. I'm sure that would be helpful, but I'm really curious if you had to articulate, are you worried or not worried about this patient? And then if you are worried, what would be the reason?
Yeah. So is this ophthalmophobia, Shema? Yeah. So I am. I'm very worried about this patient. So it's very interesting. So let's start 28 years old, right? She has hypertension. So I think we'll need to get to that very soon. But we have a subacute eye disease characterized by pain, redness, and decreased vision. So when probably and of course with the contact lenses, that's important. That changes our approach. When thinking about red eye, we cannot miss some very severe diagnoses, right? So we have keratitis. So it's basically an ulcer. We can have a bacteria or a virus or even a fungus if the patient is immunodepressed that is basically eroding the cornea. We can also have uveitis, which is basically an inflammation inside the eye, and it can be anterior and posterior. And we have also some more non-severe causes, which we can have conjunctivitis and also scleritis, which can be quite severe. So here we have a patient with contact lenses, right? And it's usually associated with Pseudomonas, the bacteria. And we have difficulty with eye movements. I think this probably is, we have a more extension of the inflammatory process, given this difficulty with eye movements. But Rabih, I would love to hear your thoughts and what do you think about all these cases and also because of the hypertension.
Yeah, I'm really glad that you put a pin in the hypertension. And in most instances, we don't have to think about why a patient has hypertension because primary or idiopathic hypertension accounts for the vast majority of it. But in some instances, and a young age being an example, we might have to question that. And that is a box we may choose to open later if it's relevant to this case. But not everything has to be relevant to the blood pressure. And I think that if you're starting in general, and if you only hear that the patient has pain in her eye, and you haven't seen her yet, say your colleague is telling you, hey, the next patient you're seeing is a patient with eye pain, I think it's really important to recognize that discomfort can fall into 4 different categories. And the 4 categories are that the patient has a headache that happens to be around the eye, and cluster headaches and migraines are an example of sometimes how it can hurt around the eye. That, of course, is much less likely when the eye is red itself, but it's an important category to recognize exists. And when the eye is red, you can really zero in on the ocular structures itself, but those are actually a little bit nuanced. And the nuance there is to recognize that there are really fundamentally 3 things that is involved around the eye. And there's the globe, which is the eye itself, which involves the conjunctiva, the cornea, the uvea. There's the orbit, and the orbit is basically the universe in which the globe is located. And then there's the ocular adnexal structures. They're the things that surround the eye on the outside. So whenever you're dealing with a red eye, the instinct is to be like, oh, it must be the eye itself, i.e. the globe, but you have to spend a moment thinking, is it actually around the eye? Is it in the eyelid? Is it in the lacrimal gland? And then also spend a moment thinking, hey, is it in the orbit? And not in the actual eye itself, but in the socket in which the eye is. And I think that's the kind of 10,000-foot view that we have to take. So all you can say here is that the neurological category is unlikely, 1, and 2, that we have to be very worried about this patient because she has many alarm features. She has the use of contact lenses, which opens up to the possibility of corneal disease. She has pain with eye movements, which is characteristic of many ocular disease, including those not in the eye, but rather in the orbit. And most alarmingly of all, she has a vital sign abnormality, and that vital sign abnormality is a reduction in vision. So I think we need a lot more data to help us localize not just where the problem is within the eye, but carefully calculate whether it's a problem of the globe, of the orbit, or of the adnexa. And I think that's the key next step. Any questions about that, Francisco? Is that concept of the trifecta of eye localization, is that clear in your mind, or should we spend a minute talking more about that?
No, I think you actually explained very clearly. I didn't have that approach, that anatomically, like dissecting in layers. So yeah, because we start thinking, okay, red eye, is it something inside the eye? But then we have pain with movements. Probably it's more it can be in the orbit, as you say.
Exactly.
So yeah, I'm curious to see what's next.
Yeah, let's do it. All right,
Amazing. Amazing discussion, you both. So I will now give you more information, and after this aliquot, I will then ask you to stop the recording because I will also show a video. So first of all, the past medical history is only the known hypertension. The family history is non-contributory, no past surgical history, no medications, allergies only to penicillin. To her vitals. So blood pressure is 151/95, heart rate 93, respiratory rate 16. She's afebrile, SpO2 is 100% under room air. And to her general exam, she is awake, alert, oriented, and no significant distress. To the heat exam, her right eye, there was ptosis, complete ophthalmoplegia, decreased visual acuity. She was only able to see superior nasal quadrant on confrontation. The left eye was normal on exam. Otherwise, respiratory, heart, abdomen, extremities, neuro exam, psychiatry was completely normal. I will also put it in the chat for the scribe. And then now, before you start discussing, I will now show the video. So please stop the recording at this moment.
You got it, Shema. Let me just emphasize to folks that if you're joining on YouTube, yet another reason to join live, but sorry that we can't share the video outline with you, but here we go.
Yeah, thank you, Shema. Great video, great neuro exam. So what we see is the patient, and a doctor is asking her to make eye movements, and we see something that actually I've never seen. So on the left eye, the patient is moving the eye freely, completely, and on the right, there's actually no movement at all. And so we do have a complete ophthalmoplegia. So the eye is not deviated, so we cannot really locate if it's to the third or fourth or sixth nerve pair lesion. We see some proptosis, so the eye globe leaving the orbit, and with ptosis associated, which is defined by a covering of the iris. This is an interesting finding. It doesn't happen always. In Graves' disease, we have the eyelid that is retracted. And these were some of the teachings that Rabih said while we were not recording. So,
Yeah.
interesting
All right,
example.
friends. You ready to have some fun?
Yeah, sure.
All right. First, I'm just so in awe of how calm you are. This is like a very tricky case, and you're just casually writing the ways, which I really, really enjoy. Okay, if I came to you, Francisco, after a soccer match, and I said, "Hey, I'm feeling weak. I can't walk on my right leg," you probably would be like, "Whoa, what kind of neurological issue is Rabih having? He can't walk on his right leg." And say then you then examined my right leg and saw that my ankle was massively swollen or otherwise proptotic. What would you conclude is the cause of my weakness? What do you think?
Yeah, there was some bad defender that probably hit you in the ankle, right?
Exactly, right? So I want you to think about that as you start to think about why this patient cannot move her eye. So just in general, I would love to hear your thoughts on how you approach ophthalmoplegia, like what thoughts you have on that, and then how you're layering in the accompanying findings of proptosis and ptosis. Like, how does that help you?
Yeah, sure. Because when we have a neurological disease, we have findings that we can anatomically define if it's the third, fourth, sixth pair. Here, it seems that probably all nerves are affected, and we have ptosis, which also signifies that the third nerve is also affected. So just like the case that you presented, maybe is it the muscle and not the nerve that is affected? So is it the muscle around the eye? It is unilateral. So is it a mass? Is it cellulitis? Um, and I always have the hypertension in the back of my mind. So uh, yeah, Rabih, what do you think about? I tried also the anatomical approach to it.
That's absolutely superb. What you're saying essentially is when you're trying to localize the causes of eye weakness, you are given a free B when you see that there is other signs of disease affecting the eye. So the fact that the eye is sticking out and that it is ptotic tells you the localization is likely in the eye. No different than if you saw that my right ankle was swollen, you wouldn't have to think about a brain tumor. The disease is declaring itself right there. And so I think what I was trying to pull up was a schema for for orbital weakness. But in summary, ocular weakness accompanied by orbital signs localizes the disease to the actual orbit. And it's a really important point because many of the times when you're dealing with ophthalmoplegia, the patient has no local findings except weakness. This patient does not have that. So if we go back to our original schema of, is this a disease of the eye itself, the adnexal structures, or the orbit? This is looking like it's a disease of the orbit. And the question is it a disease of the orbit because of problems with the inherent orbital structures, namely the orbital muscles? Or is there something in the orbit that should not be there? So if you imagine that you can take a picture of this person's eye in your mind, and you just picture that there's something wrong with her muscles, that they're swollen or tense, or there's something like that shouldn't be there, like a mass or an abscess. And if you're trying to make a mental visual model of this, you're like, okay, orbital disease, a problem inherent to the orbit, i.e. an orbital muscle issue, or a problem that shouldn't be there. And the next question is, for a structure that shouldn't be there, is it in the orbit, or is it extending from the peri-orbital structures? So this is a tough one, but important one for you to think about, Francisco. Can you think of anything close to the orbit that might invade in the orbit?
So the orbit connects with the sinuses, the maxillary sinuses, and it also connects with the cavernous sinus.
Superb.
And I think that's it.
That's exactly it. That's all you need to say. The word sinus. That's really, really key. So now let's summarize. We were first given a lot of concern about eye stuff. And as soon as you hear eye stuff, you have to think, is it in the orbit, the globe, or the adnexa? The presence of ocular movement abnormalities almost confirms an orbital disease process, which may be intrinsic to the orbit, like lacrimal gland enlargement or orbital muscle disease, or it may be something that should not be there, which may be restricted to the orbit, like an orbital lymphoma or an orbital melanoma, or may be invading from the adjacent structures, namely the sinuses, nasal, ethmoid, maxillary, or cavernous. So what would you think, Francisco, is the highest yield next step for you? What would you think if you had to pick the data that would come next that would help you solve this problem as quickly as possible? What would you want next?
I think I would want a CT with contrast, probably. Yeah. I think that would be very important, and soon. I think.
Exactly right. I think CT versus MRI of the orbit is the best test. CT will happen much quicker than an MRI.
Oh, yeah.
You were telling me that you use a lot of point of care ultrasound. And I will tell you that the point of care ultrasound is in line with using the stethoscope in many ways. I will explain after the CT why you might really need to use your stethoscope here for one specific diagnosis.
Is it see if it's pulsating?
Yes, exactly right. So hold that thought. But I don't use my stethoscope much anymore because of all the amazing tools that we have. They'll use it occasionally, but this is one time where I'd be looking to see if I hear pulsations. But that's a complex thought that we probably need to revisit at the end just as a teaching point. But that's the exam that I would do next. And then I think blood work and imaging with CT probably being very, very high yield. All right. Shayla, tell us more.
Amazing discussion. I also have to give a shout out to you both because I feel like you're both doing ophthalmology. It's crazy how good you are. So first, so to the third aliquot, so the labs. So first of all, with the white blood count, it was 12.4. Hemoglobin was 12.9, and hematocrit was 40.4, MCV 84. MCH 27, platelets 210, ESR 17, and the electrolytes, glucose, LFTs were completely normal. And we also did a point of care beta HCG, which was negative. And now I will give you some imaging findings. So you are requesting a CT. So a CT it didn't show any acute intracranial pathology, but it showed thickened appearance of the optic nerve on the right. And then we also performed an MRI. So an MRI of head brain with and without contrast, and an MRI of the orbit, which showed abnormal appearance of the right globe with unilateral papilledema and optic nerve swelling, neuritis and perineuritis, and the right superior ophthalmic vein appeared mildly prominent, distended with respect to the left. And as you also discussed, that there was significant proptosis also seen. There was no appreciable cavernous sinus filling defect, no convincing signs of cavernous sinus thrombosis. and that's the end of third aliquot.
Wow, very, very intriguing. I'll give Francisco a moment just to collect your thoughts. But Shima, just to clarify, the white count was 20,400, right? Is that? Oh,
No, it was 12.4.
12.4. Okay, got you. So the white count is normal, essentially 12.4, and the hemoglobin is also normal? So, okay, so is it fair to summarize that the labs are negative and the imaging is intriguing? Yeah, okay. Yeah, so that's super, super helpful. All right, Francisco, what are you thinking? I gotta tell you, this is tough. What do you think?
Yeah, I think, like you say very frequently, the negatives are also important, right? So it's important. It might have seemed that we didn't make a lot of progress, but I think we did. So when I was seeing the white blood cell count, 20,000, I was thinking, does she have some sort of infection that led to the thrombosed veins? So I think she had a distended vein, right? Superior ophthalmic vein. Okay. Yeah, superior ophthalmic vein. So, but now, is the vein distended and enlarged not because of a cavernous sinus thrombosis, but is it like causing all this, or is it just a consequence of all the inflammation, the nephritis, and the perinephritis that is happening? Because I was surprised with the optic swelling, the optic nerve swelling. Yeah, what do you think, Rabih? It's intriguing.
Sometimes I wonder, why do we do this? Like, why do we just sit here and try to solve these really, really hard cases? And this is one of those times where I'm just so glad that you're here and that everybody's here, because I actually, I'm having a very hard time with this. But I think let's just go back to my injured leg, okay? Because I need to go back to familiar territory. There's only two reasons why things swell up. Inflammation, they're inflamed, like cellulitis of the leg, or they're under high pressure. You have to think about, like, why would something be swollen? It's because it's inflamed or it's under high pressure. By the way, that sentence is basically equivalent to saying a pleural effusion is transitate, high pressure, or exudate, inflamed. And red is leg. A leg is red. Is it infected or inflamed, or is it under venous hypertension? So I'm borrowing that very simplistic model because I see so many things are swollen. Basically, Shema said the eye is swollen, the vein is distended, the eye is sticking out, the optic nerve is swollen. And the question, Francisco, is the eye swollen because it's inflamed? Or is the eye swollen because it's under pressure? And so I'd love for you to take that model and see what your best guess is. Are you going more it's inflamed, or are you going more that it's under some form of pressure?
Well, I think I've never heard so simply how things can get swollen. So inflammation and high pressure, and you can apply it basically to every organ. That
think so.
I
hope so.
Wow. No, amazing. So I think, given the thickness of the optic nerve and this increased sign in the MRI, I would favor inflammation. I don't see any evidence for the high pressure, but we actually we have papilledema, right? We have papilledema, and we have a vein that is distended. So
you're making a U-turn. I'm glad you did it.
So is it high pressure?
I think so.
Okay, yeah. 360 turn.
I made that same U-turn you did. It's not 360 because you'd be back where it's 180. Yeah, 180. I think it's hard to know. So it's really, really hard to know, but I think when the eye is the clue, by the way, was in the video, I think. So you're like, is it pressure or is it inflammation? And you see the word optic neuritis. It's hard not to think inflammation, but then you see that there's papilledema, there is the vein is distended, and then the eye is sticking out. Francisco, remember that, what do the eyes look like? They were not red at all. There was no redness on the ocular surface. And that has me really worried that this patient has a swelling process. And based on the fact that the vein is distended, I'm a little worried that that swelling process involves the venous system, right? And that's tricky because there's no corroboration of that, because they're saying that there's no distal occlusion. So how can you get venous hypertension, which we can infer by the fact that the superior ophthalmic vein is distended, and that distension of the vein is impairing venous drainage of the orbital muscles and of the optic nerve, causing a orbital syndrome, causing a nerve syndrome, and and so, but without occlusion. So
is it?
Yeah. What are your thoughts?
So the only thought that I have in my mind is probably a fistula. And probably that's why you were asking way before if we could auscultate, right? And I don't know if when we can we see it when we are palpating the eye? If we see like some pulsation? No, we don't.
Francisco, when I ask these questions, I often have a pretest probability of how often you'll get it right or wrong. I was not expecting you to say that. And I was expecting to spend 5 minutes to try to deduce that and talk about that. But you got there way before I was going to. That was amazing. Oh, no. That's absolutely right. So the fundamental question is, how do you get venous hypertension without thrombosis? There's two answers. The first is valve insufficiency. We see that a lot in venous stasis. The valves don't work. And the other answer is a fistula, where the artery is connected to the vein and the vein is under high pressure. And so you're absolutely right. There are no reasons to have a venous valve insufficiency in the eye. And so the question is, could this person have a fistula? And you're absolutely right. This case is very, very suspicious for what is called a carotid cavernous fistula. So have you heard of that entity before, or know anything about it from in general?
I think I've heard it most definitely. I just don't know how we could get it.
Yeah, excellent.
Yeah.
There's two kinds of carotid cavernous fistulas. There's a direct and indirect, and the long story is they really are inferences about how high the flow rate is between the carotid artery and the cavernous sinus. An indirect fistula implies that the connection is very low, and the syndrome is a slowly progressive one. A direct carotid cavernous fistula is a high flow fistula that presents like this. So why would somebody have a carotid cavernous fistula? I think a large fraction of them are idiopathic, but a reasonable number of them have a underlying connective tissue disease. I'm left wondering now if the patient has the patient's hypertension could be linked into this, but I think that's too far-fetched a hypothesis now. So I think you really got there, Francisco. Edema, is it inflammation, or is it venous? Is it under pressure? And the distension of the vein is very much a pressure phenomenon. When there's a venous distension without occlusion, think valvular insufficiency or fistula. And here I think there's no reason for valvular insufficiency. So I think thinking about a fistula is really important in this case. And indirect fistulas are very, very hard to pick up because they're tiny connections and often require advanced imaging. though including a CT with contrast or sometimes invasive angiography. But sometimes a very simple maneuver, going back to the exam, of putting the stethoscope over the periorbital structures can allow you to hear some music which you should not hear, and that can modulate your suspicion. Any questions about that, Francisco, before we learn from Shema what they did? And if we're horribly wrong, hopefully she'll course correct us.
No, so it's just great thoughts, Rabih. I think you were thinking about that way before, but this process, this reasoning was very stimulating, and I didn't know about those indirect fistulas because we don't have imaging, but I'll just say fistula because I don't know, because I thought we could maybe see it, but yeah, very interesting. I don't know if the next is the last aliquot or if we have something.
I have only one aliquot left before revealing what the team diagnosed. So I have to say I love this Irish discussion so far, and now I'm giving you the last aliquot to discuss. So Wave performed an MR angiogram of the head and carotids that didn't show any arterial occlusion, stenosis, or aneurysm. They also performed CT abdomen pelvis with IV contrast that showed a complex 4 centimeter cystic lesion in the right ovary. The ultrasound of the ovary showed only a simple right ovarian cyst. They also performed an extensive infectious and inflammatory workup. So they performed an LP that showed largely normal results. And they also performed some testing for HIV syphilis that was negative, testing for ANA, anti-double-stranded DNA, and complements was also completely fine, so normal. So yeah, that's the final information before revealing the final DX.
What are you thinking, Francisco?
Wow, so is it really idiopathic? It doesn't seem to have the page. So ovarian cyst, it's okay, it's normal, right? It's a normal finding. So but we still have the hypertension. I don't know, probably it's a more extensive workup, and they will do it in outpatient setting. I don't know. But yeah, I don't have much to add, Rabih.
Yeah, I think it's really fundamentally very tricky. And I'm glad we got to do the thinking that we did. At the end of the day, when you get more and more imaging that's saying that there isn't a fistula, you have to humbly accept to reduce that pretest probability, but also be open to the fact that a fistula may be so small that you need invasive angiography to detect it, as we talked about. But I think, Francisco, if we were to simplify this problem, we're saying that this is image negative orbital disease, right? We have an orbital disease, which we've confirmed, but the imaging is not fully revealing. And so I think the key fundamental question is the imaging truly underwhelming, or is it falsely negative? And the real question is, will more advanced imaging, like an invasive angiography, reveal an answer? And if that's true, I think the answer would probably be a carotid cavernous fistula. But say the imaging remains completely negative, and then we call this a image negative orbital disease. There are some considerations that fall under that. And the main one to know about is an entity called Tolosa-Hunt syndrome, which is basically a localized version of, it's a granulomatous orbital syndrome, is a localized version of sarcoidosis. It's basically sarcoid of the orbit without any systemic features. This patient has features suggestive of Tolosa-Hunt, with the fact that she has unilateral ophthalmoplegia and it hurts, but it is fairly unusual in Tolosa-Hunt to get vision loss or to get orbital nerve involvement. So if I were the treating providers, I would be wondering, is it time for steroids to see if this is a autoinflammatory disease of the orbit, which will be inherently image unrevealing? or is this an image positive disease? And what I've seen image positive, is it a fistula or is it an infiltrative tumor of the eye? There have been really interesting cases of leukemias and lymphomas not taking up space. So where I'm at, I'm really curious to get your thoughts is inherently image negative. Is this a steroid responsive disease on the spectrum of Tolosa Hunt? But if the imaging turns out to be positive, then I think a carotid cavernous fistula makes sense, or an infiltrating tumor. I think with the venous hypertension, it's really hard not to worry most about a carotid cavernous fistula, and that would be my. How would I solve it in real life? I'd probably recommend invasive angiography in this person, just to make sure that that's not the case. But I'm curious where you're at. I know this is a very, very complex case.
Wow, like I've heard about the carotid cavernous fistula, but that syndrome I've never heard at all. But it's interesting. So yeah, probably that would be a very interesting step. And if it's in, so if I understood correctly, if it's that exam is indeed negative, we will try steroids and confirm it. Right. Very, very interesting. And the hypertension, we just skip it, probably. Well,
Yeah, I think that if you ask yourself what are the most common causes of secondary hypertension that is not primary, it really focuses on their kidney and the ad kidney or the adrenal, including renal artery disease like fibromuscular dysplasia, or renal parenchymal disease, and then adrenal issues. And I think the fact that we've imaged her kidneys and vasculature and her adrenals, I think is going to make it a little bit less likely that we easily discover her cause of secondary hypertension, though it may be some other things that are hard to see, like OSA. But I think that it does reinforce the possibility that there is damage to the carotid artery and a fistula as a result of that blood pressure issue. So I don't think I can see an underlying cause, but I'm worried that there might be a consequence of that blood pressure. Yeah.
oh yeah.
Did you sniff out anything that might help you think, oh, I think this is hypertension from blank?
No, actually not. So we usually debate a lot if these manifestations are causes of consequences. So
Yeah.
if you think that probably it's a consequence, yeah, probably it is. Yeah, I was thinking as part of the cause, not
Right.
of the consequence. So that's an interesting thought. Yeah. So I'm very curious to see
Shema has
they
made,
did.
Shema has made me tremulous a little bit.
Amazing discussion. So I have to say, because you had an amazing discussion, I just changed one part. Like, I will also give a little bit information and just give the mic again to you just to share your final thoughts before revealing what the team was thinking. So as you said, she was started on methylprednisolone 250 milligrams IV every 6 hours, and also broad spectrum IV antibiotics, including ceftriaxone, vancomycin, metronidazole. Initially, it was considered that the patient might need decompressive surgery by neuro-ophthalmology. However, the patient's eye exam improved significantly a day after starting treatment, and she reported feeling much better. Unfortunately, due to personal issues, she requested to be discharged home with outpatient follow-up. The patient was discharged home on oral steroids and antibiotics with close follow-up with ophthalmology within 24 hours. And then I will share what the team was thinking, why we started this treatment.
What do you think, Francisco?
I think you are correct. Did she improve because of the steroids? Probably,
Yeah.
right?
Where do you think we went wrong initially? Now that you know she's improved with steroids, what do you think was the wrong branch point in the schema?
So we had no signs of inflammation, right?
But now she's gotten better with anti-inflammatory therapy,
Yeah.
right? So maybe
So
I should have guided you to make that U-turn.
No, yeah. So usually we see red eye, and when we have uveitis, it's a huge probability that probably it's autoimmune disease.
Yeah.
But then we saw the video. The patient did not have red eye. She did not have any marker of inflammation. So no, so I think it was I don't know where we got wrong, but this was surprising,
Yeah.
very surprising.
I'm very, very surprised. I think that the response to steroids is very powerful and goes to show you how, and actually in many orbital issues, steroids are used to try to figure out if the patient has an underlying autoimmune disease or not, in large part because the tests that are available are very limited. But I think we use the vein as a reason as to why there is high pressure. And then we made the inference that the vein is either valvular insufficiency or has a fistula, but that we were missing something. And the thing we were missing is local hypertension from a compressive process on the vein. Was there something that was inherently under high pressure compressing the vein? So a good example of this might be that if you have a mediastinal mass compressing on the SVC, right? SVC syndrome is a great example. So was there so much pressure in the eye that the vein was dilated and everything was backing up as a consequence? In summary, the mistake that I made in my thinking was to say the word or. Does she have inflammation or high pressure? And I'll share the argument that I think she actually has both. She has steroid responsive disease, which means she was inflamed. But was she so inflamed in her orbit that she then impaired her venous drainage and caused her eye to bulge out? And what is the argument for this is knowledge about the likely underlying disease. And if you think of autoimmune disease plus orbit, they did a systemic workup to make sure none of these systemic diseases that were at play. And the fact that they weren't means that she has one of these three conditions. She either has inflammatory pseudotumor of the orbit, Tolosa-Hunt, or orbital myositis. And Tolosa-Hunt should cause ophthalmoplegia without optic nerve involvement. Orbital myositis should cause orbital muscle weakness without optic nerve involvement. And what distinguishes inflammatory pseudotumor from all the other categories, it is inflammatory, but the word pseudotumor is used to imply that the patient is under such high pressure in the orbit that there are tumor-like effects, no different than the word pseudotumor cerebri of the brain, high pressure, but without actually a mass. So I think, Francisco, the mistake I made was to use the word or. I think this patient definitely has inflammation, and I think the inflammation was causing pressure effects. So my best guess for this person was that she had inflammatory pseudotumor. And then that got better with steroids. I don't know enough about the condition, about who it happens in or why, but I think the mistake, again, was to say or and not and. How does that jive with you? And yeah, I feel like I'm talking a lot. I'm curious to get your reflections on that, that hypothesis.
Yeah, so it's interesting that I thought that inflammation increases pressure.
Mhm.
So when we were thinking, her findings mostly favored increased pressure, right? So I think it was the logic thing to try to think for a fistula. But this inflammation, so when I think of inflammation, I think of something more systemic, right? And
Yeah.
even if she just has inflammation not in both eyes, in just one eye, right? That's Very interesting. So it really expanded all my differential diagnosis in approaching, which was not very broad to start
No.
with.
It was pretty good. It was really, really good. Well, no matter what, we're going to learn a lot from this case. And I think you can ground yourself in just the simple aspects of, I think globe, orbit, adnexa. Remember that forever, because most of us thought this was going to be a problem of the eye, and it turned out to be an orbital problem. And then you can study orbit diseases for the rest of your life, I guarantee you. But I think that's the fundamentals. And an orbital disease is fundamentally, is it a pressure disease or is it inflammation? And the error that I made was, it's not or, it could be and. But let's see what Shema has in store for us.
So amazing discussion, and now giving you what the team was thinking. So she was seen by ophthalmology and neurology in the ED, and based on the clinical onset, the exam findings, and imaging, she was diagnosed with orbital apex syndrome, but the etiology could not be determined. So there was no evidence of sinus or any other infection, inflammatory process, MS, or any neoplastic process clinically or on imaging. The patient reported no personal or family history of cancer or rheumatological diseases. However, part of the workup, including NMDA, MS, neuromyelitis optica, toxoplasma, APS, Sjogren's, TB still remains pending. So the etiology of her orbital apex syndrome still remains undetermined. And still, whereas just some few teaching points that I have for this case. So just anatomically, as you said, if only the cavernous sinus is being affected, we wouldn't expect the involvement of, I mean, what was it? If we expect the involvement of the fissura orbitalis superior, we wouldn't expect an involvement of the optic nerve, but the orbital apex incorporates the optic canal and the superior orbital fissure. And due to the anatomical proximity, we can have two other syndromes that can have overlapping features like cavernous sinus syndrome, but this would also be accompanied by facial pain because the second branch of the trigeminal nerve is also there. And on fissura orbitalis superior syndrome, the optic nerve would be spared. And the etiology for the syndrome is so diverse, so we still don't know the etiology, but let me know what you think so far.
Oh, Shema, this is an incredible case. I feel like Francisco has probably gotten the hardest VMR case ever to have to co-solve. I'll just share this visual so you can all reflect on it later, because I think we're a little short on time, but here you can take a quick screenshot of it. So these are the different localizations in the orbit. There are some really nice review articles: superior orbital fissure, orbital apex, cavernous sinus, and the dash is meant to see that these things are down. So you can see in the cavernous sinus, all these things are not working. And in orbital apex, we had that today. We had 3, 4, and 6, and then cranial nerve 2. But yeah, I think you've essentially diagnosed idiopathic orbital apex syndrome, which I think if you go down that category, it's I have a lot more reading to do. I'm excited to do that. But I think, as you said, Francisco, this case ultimately for me is going to show you the power of the pertinent negatives. And like, you're essentially diagnosing this idiopathic inflammatory condition because nothing else has popped up. But yeah, a lot more reflecting to do on this case. Before we ask you, Shema, to outline what you learned and what you like, why you learned a lot from this case, I'm curious, Francisco, how did it feel to discuss it? What do you feel like were big takeaways for you?
Well, this was, I think, not at all the hardest case. I felt like it was so complex, but the way you put it makes it sound so simple. You know, the approach to orbit disease and to disease of the eye in general, and really the importance of the negatives. I think that's also very important. So it started with a phobia of Shema, and now I think she has to apply for the ophthalmology match after this case.
From a phobia to a philia. Shema, what did you get out of this?
And what was the question? I didn't understand.
We are both, Francisco and I are very curious what you learned from this case and why you thought to bring it here today.
I have to say I learned everything, like because it's an Irish case. Like, I mean, I was always listening to all the case discussions and there was like, oh gosh, there's again blurry vision and so on. And I was always having these difficulties. And I really loved the discussion when it was going on with how we can divide the structures within the eyes, which helps us to make more progress. Okay, where can this disease be located? And I really had difficulties, but I would say after this discussion I have learned so much more, so I can tell you I might not become an ophthalmologist, but even, I mean, I'm still between internal medicine and derm, but I mean, even on derm, I see Irish case, like I had a Zoster case like last week. So, and there was optic involvement. So yes, we always have to keep, the subspecialties are not always that divided. There's always a combination, even on derm and eye.
I love how you call it an eye-ish case because it's never just an eye case. There's always a little bit of an inch. Rabih, what was it like for you to be involved in this case?
Oh, I was totally lost, but I just loved the video and the findings. I've been itching to bring the case, and then talking to Shema, I was like, why don't you present the case and I'll back you up? But I just think it was a great breakdown, even though we don't know the final outcome. I think we may come across it in the emergency room. If you've seen quite a few patients with eye problems in the emergency room, to at least know a starting point, where to tackle a case and who to consult. And then just like you very easily mentioned, like, is it the eye? Is it the globe? I mean, is it the orbit? That's a very good breakdown. I think that's pretty much what I learned or took away from this case.
Amazing. Well, Francisco, thank you for diving deep with me all the way to the orbital apex. We made it to that specific spot. And really, really excited for Reshma to recap the teaching points. Reshma, maybe for the sake of time, since we babbled away, you can share with us two or three of your favorite teaching points, because I know there was a lot. And yeah, maybe you can hit the highlights for us.
Sure. I think the most important thing that Rabih mentioned today was he said reduction in vision is an important vital cell abnormality. That struck so hard, because I mean, we never know. We always think abnormalities with blood pressure, pulse rate is the most important thing. And the other thing is what Rabih mentioned again, like how we kind of like divided inflammation and pressure symptoms. So we could always think inflammation could cause the obstruction. So basically inflammation always comes with edema, right? Like, so anything edematous could cause an obstruction, which would definitely result in increase in pressure that could lead to pressure symptoms. So I think these are the two main takeaways from today.
Oh my God, I can't believe you were able to do that. I completely agree. Vision is a major vital sign, and when something is swollen, think high pressure or inflammation. Absolutely superb. Thank you, Reshma. That was very, very impressive. All right, y'all. I hope you have a wonderful rest of your day. As a heads up, the time for RLR VMR tomorrow is a little bit unusual. It's 2 hours earlier than you're used to at 7 a.m. Pacific, because Prof. Rez is waking up early like I am now. He's joining the early morning club, and I hope you all will too. See you later.
Bye, friends.
Bye.